A warm welcome to the Fortis series. Myself, Dr. Padma Priya. I am a pediatric ophthalmologist and squint surgeon at Dr. Agarwals Eye Hospital, Shoring. Today's topic is about approach, evaluation, and management of pediatric squint. We all know that squint is not just a mere misalignment of the eyes. It is much more than that. So squint evaluation needs a detailed approach right from proper vision documentation, refraction to posterior segment examination. All the more sounds complex, and pediatrics squint sounds all the way even more complex. So we have with us Dr. Divya Motwani to simplify and elaborate us on this complex topic. Welcome, Dr. Divya Motwani. I also take pleasure in inviting our expert panelist, Dr. Manjula Jayakumar and Dr. Sreepathi sir. Welcome, ma'am. Welcome, sir. So, Dr. Manjula Jayakumar, I'm happy to share that she is my mentor and teacher. And she has done her undergraduate from Government Kilpauk Medical College, postgraduate from the prestigious Shankara Nethralaya. She's done her FICO in Ophthal from UK, passed with credit, and she has done her fellowship training in pediatric ophthalmology from SN. She's a renowned teacher, mentor, and a surgical innovator with a very deep knowledge in the subject. She is an innovator in many surgical methodologies like modified fade and operation, for which she was awarded the Best IJO award for her modified fade and approach. She has been awarded many accolades and credits. Recently, she's been given the I-Star Award by Dr. Agarwals Eye Hospital. She is a prestigious faculty of DNB Board and Fellowship Training Program. She has many publications to her name in national and international journals, and I'm proud to be her student. We welcome you on board, ma'am, to share your expertise and knowledge. We welcome Dr. Sreepathi sir. He serves as the Regional Head Clinical Services at Dr. Agarwal's Eye Hospital, Yelahanka, Bangalore. He is highly experienced with over 19 years of clinical expertise and has successfully performed more than 40,000 eye surgeries. His area of specialization includes advanced cataract surgery, pediatric ophthalmology, cataract surgeries, squint, and also oculoplasty. With extensive experience in comprehensive general ophthalmology, we welcome you on aboard, sir. We have our speaker, Dr. Divya Motwani. She is a pediatric consultant at Dr. Agarwal's Delhi Main Hospital. Her expertise is in pediatric ophthalmology, strabismus, neuro-ophthalmology with 8 years of experience, and she's an alumni of prestigious LVPI Institute. She's a passionate mentor and teacher. We are all ears to listen to her. Welcome, Dr. Divya.
First of all, thank you so much for having me to be the speaker with such a wonderful panel today in front of us. And it's my great delight to be talking about pediatric strabismus approach, evaluation, and management. So it's a very vast topic. We'll be covering as much as we can. I don't have any financial disclosures. So let's build the foundations first, as Dr. Padma already introduced, that around 40% of Indian population are actually children below 16 years of age, of which the global prevalence of strabismus among children ranges from 0.14 to 5.65%. That means that approximately 1 out of every 40 to 50 child have squint. Now, that's not a very small number. Looking into the prevalence, we can see that the ESO deviations are more common as compared to exo deviations in children. Amblyopia risk definitely increases a lot more in untreated strabismus, and that causes failure of development of binocular vision. They not only have visual problems but also have a psychological and a psychosocial impact, causing the stigma, reduced self esteem, and even restricted career options persisting in adulthoods. Further serious problems might be present, and this can be actually a presenting sign, like in case of retinoblastomas, other kind of tumors. Patients might even have hydrocephalus, a brain tumor, even like having anorchiari malformation. They also present many a times with actually an ESO deviation. So what all to look at when we have a child with strabismus in our OPD? The first and the foremost is the history. So, chief complaint, birth history, development history, the family history, this all plays a very, very important role. We should also look at the child on the whole, check for any systemic complaints or any other significant history in the past. Risk factors have to be looked at for. We should screen for the red flag signs, vision and cycloplegic refraction, the type of squint, the evaluation based on the sensory and the motor evaluation of squint, a proper family album tomography to see when the squint developed and how frequently it was seen, and as well as a detailed anterior and posterior segment evaluation. Let's dig in further. So, coming to the step one, that is history. What are we supposed to ask? First, go for the deviation profile, of course. So, the parents come with the complaint. So, we need to ask, when was the squint noted for the first time? Which eye was it? Was it in both the eyes? What kind of direction do they actually see? How frequent is it? Is it consistent, or do they see it sometimes? Further, asking about diplopia, presence of any binocular diplopia, which is horizontal or vertical, or any other kind that they have been or the child has been noticing. Further, a proper background, that is, knowing about the birth history, knowing about developmental milestones, any current glass wear, and even family history of strabismus or any childhood eye surgery in first degree relatives, as we know that squints can also be present in families, like in case of congenital fibrosis. Now, knowing the risk factors in these histories is very important. So, the first being prematurity, low birth weight, any forceps or cesarean delivery, history of any maternal smoking, or even any maternal infections during pregnancy. Systemic complaints like Down syndrome, cerebral palsy, craniofacial syndromes, fetal alcohol syndrome, or even developmental delays. We need to really check for all of these because they warrant high surveillance, because they can have squint more commonly as compared to children without these risk factors. Now, presence of any other ocular history like any unilateral ocular disease, any trauma, high refractive errors, anisometropia, or even meridional anisometropia should be checked for. Genetic history, that is, checking if their family has a history of strabismus, as we discussed even before, should be asked. Now, coming to the step two, that is the visual acuity assessment. Every child has to go through this, and it is not true for a fact that if the child is an infant we cannot check the vision. No, we really can. By forced choice, we can check even if there is a steady constant maintenance of vision, or if there is a dazzle reflex that is present. In children who are less than 2 years of age, grading based acuity with the help of Cardiff charts can be used. Even pictures charts, which are uncrowded from children who are less than 3 years of age, can be checked. Children who can read can go ahead with Snellen or Logma, and crowded tests are usually preferred as early as possible for accurate amblyopia detection. Further, the key principles are that we should always check the vision monocularly first, because binocular vision assessment will mask amblyopia. So, definitely a binocular vision should also be checked to see the best visual potential, especially in children with nystagmus, but monocular vision is the key. The second being crowded tests are preferred because crowding effect they reveal amblyopia even if it is not detectable with isolated optotypes. Further, we have with the vision acuity testing, we can get to the glass prescription, we can get to the grade of amblyopia, the need for therapy, and even the surgical timing. Fixation pattern, if this is central, steady, or maintained, is an essential assessment in preverbal children. The third and one of the most important step is cycloplegic refraction. So the agent of choice, at least for me, is cyclopentolate. And in some children who are really small in age or have a history of seizures or other neurological or developmental issues, homide is a drug of choice. And in patients who have high hyperopes or we are suspecting to have a high accommodation, we should go ahead with atropine refraction. Why is this essential? It basically eliminates the accommodative component and relieves the true underlying refractive error. Now, the key findings are that in high hyperopias, accommodative esotropias are more common. In high myopes, they are at an risk of exotropia more, while anisometropia can also cause amblyopia, and further, the presence of strabismus might be there. Now, cycloplegic refraction is a mandate in all children, irrespective of presence or absence of squint. We should never miss it. Further, next, coming to the sensory evaluation of squint. So, before we jump into the tests, what we need to understand is what are corresponding retinal points. So, as we see here, if a patient who is actually focusing at a central point and has a foveal fixation, both the foveas are looking at the single point. But uh, what about the images in the periphery? So, if this A image falls on a point in the left eye that is nasal to the fovea, the same image is falling on the point that is temporal to the fovea in the other eye, and these are the corresponding retinal points. We need to understand this for further sensory evaluation. So, sensory evaluation basically uh, sees the presence of confusion or diplopia, sees the degree of suppression, the degree of amblyopia, the type of intraocular relationship, that is the presence of normal or anomalous retinal correspondence, and that of stereopsis. So, what is the difference between confusion and diplopia? Confusion is when one eye is seeing one object while the other eye, because of the squint, is focusing with the fovea on the other object, and that superimposition causes confusion. While diplopia is when the patient is actually seeing the same object, but because of the squint, the presence in the spatial environment changes, causing a diplopia of that object. Further, coming to the basic red filter test that we do on everyday basis in patients with double vision, it can help us in identifying what kind of double vision is present, if it is a crossed or an uncrossed, a horizontal or a vertical, or even a torsional diplopia. So, as you can see in the first image, the patient is having an ESO deviation, and therefore the patient perceives an uncrossed diplopia, while in the other image, the patient is having an exodeviation, therefore perceiving a crossed diplopia. Other tests like Maddox rod test also helps in eliciting this kind of diplopia in strabismus patients. So, using the Maddox rod in front of the deviating eye, if the patient is having a horizontal deviation, you need to make the cylinders horizontal itself so that the patient is perceiving a light which is vertical. Thereafter, knowing that if it is an uncrossed or a crossed or vertically how it is aligned helps us to show the kind of deviation as well as kind of diplopia. This also helps in paradoxical diplopias as well post operatively. Further, the use of Worth-4 dot test and Bagolini striated glass test is also helpful, not only knowing diplopia but also suppression in patients. So, we'll be coming to that further. But what are the nature's way of preventing this diplopia of confusion? Because we get so many children who do not really complain of this diplopia or confusion. So it is the presence of suppression, amblyopia, or abnormal retinal correspondence. Now, suppression is something that can develop in a period of 8 to 9 years. Before that, the eyes can go into suppression, and is something which is a binocular phenomena and not a monocular one. But in this, what happens is that there is an active central inhibition of the confusing images that are originating from the retina of the deviated eye. It can either be alternating suppression or it can be a monoocular suppression. Now, we should not get confused in the presence of suppression and amblyopia. Both can actually even coexist. The four prism diopter base out prism test is very much helpful in identifying even minor suppression in patients. So it determines whether a patient has a bifoveal fixation or not. It also picks up small suppression, and it also helps to assess the quality of binocular vision in postoperative periods as well. So, understanding a little bit about how to do this so called thought to be complicated test is actually a little simple. So, now whenever we place a four prism diopter base out, both the eyes move. So the eye in which the base prism is kept would adduct or move towards the apex, and at the same time, the other eye would also abduct, that is, move away. Now, when a patient has a good amount of fixation, this eye, the other eye, should be seen to adduct again to form that fusion. But what if this does not happen and the eye stays abducted? It can occur when there is a small amount of suppression that is present in the other eye, or it can even happen when there is problem in the fusional convergence. If the patient is having a problem in the fusion, then the patient will experience a diplopia in that abducted state. Further, coming to the Worth 4 dot test, as we know that this is based on the red and green filter. So R is in front of the right eye and the green in front of the left eye. In a normal patient who is having a good amount of uh, by in binocular vision, they perceive to have either two red and two green images that they see. Now, if a patient is having suppression, in case of a left eye suppression, they can perceive only two red. If they have a right eye suppression, they can perceive three green. And if they have a diplopia, this is the kind of image that they will be telling about. Further, this Worth 4 dot test can be done for distance as well as near. So, if a patient has a large suppression, as you can see over here, they perceive only the lights of one eye. But what if there is a small amount of suppression? Now, in case when we do this test at a distance of 6 meters, even central 4 degree of suppression scotoma can be caught. But that's not the case for near. So, in case of near, the amount of variation in the light that is entering into the eye, the degree will change, and because of which the suppression area will fall lesser than the amount of the red two dots. So therefore you can actually perceive all the four dots or have a binocular perception in cases of patients who have a small suppression scotoma, and we do a Worth 4 dot only for near. That's why it should be done for both distance and near. Further, coming to the red filter test that we had previously discussed as well, this can be used to not only check where the kind of what the kind of diplopia is, but also to check the presence of ARC suppression and NRC. So basically, as we know that the red filter test tells us that there is an uncrossed diplopia in case of an esotropia, there's a crossed diplopia in case of an exotropia. But what if the patient is having a suppression as well? So that is when they don't have any diplopia in this case, as you see over here. The patient will perceive only the one dot and not the other point source. And we can actually check if there is an ARC or an NRC present. This is done by using again a small prism or four prism diopter with base up. So what actually happens is that the image of that light source shifts outside the area of suppression. Now, if the patient has ARC, that patient would see the light, like in this case with esotropia, would see the light just below the point source, that is the red, just below that, because there's a shift in the image. But that shows that there's an ARC present because there's no horizontal diplopia happening. But if the patient has a normal retinal correspondence, the shift of image outside the suppression area will definitely occur, but even there would be an uncrossed diplopia that is occurring. Now, what is an anomalous retinal correspondence? It is basically a condition in which the two foveas have different visual directions. The fovea of the fixating eye has acquired an anomalous common visual direction as the peripheral element of the deviated eye. Now, this can either be harmonious or unharmonious. In case of harmonious correspondence, what happens is that the amount of shift in the visual direction fully compensates the deviation. As we saw in this image, that it is fully compensating the deviation as present right below the central red dot. But in unharmonious ARC, it is not fully compensated. So you will have a little bit of horizontal deviation as well that would be seen, or a horizontal diplopia as well that would be seen, but not completely equating to the amount of deviation. Further, coming to the tests of stereopsis, there are various amount of steps tests that can be done. The most common one being the Randot test and the Titmus fly test. Further, there is a Langai stereoacuity test also. Now, these tests for stereopsis should again be done for distance and near. The fifth component being the squint motor evaluation. Now, the first being the cover uncover test, which helps us to check the tropias, that is the manifest squint. If there is an inward movement, there is an exotropia. If there's an outward, there's an eso. Same goes to the hyper and the hypo. Alternate cover tests, they help in breaking the fusion completely, and therefore it reveals the total deviation, including the latent Fourier component as well. Now, the prism cover test basically helps in quantifying the deviation. So, it helps in neutralizing the movement with increase in prism diopters, and therefore, systematically doing it is very important in all distance and near, in all nine gazes, as well as with and without glasses. Further, in children, it's very, very important to differentiate pseudostrabismus from a true strabismus because in younger age group, it is very common to have a broad nasal bridge, to have epicanthal folds, for which we mistake it as an esotropia, but it is actually a pseudo-esotropia, or a wide IPD where we mistake it as a squint, where it is an exodeviation, but it is actually a pseudo-exotropia. Further coming to the ocular motility assessment, now versions and ductions in all nine positions of gaze is necessary. We should document overacting and underacting muscle deviations, check for AV patterns, dissociated vertical and horizontal deviations, check for saccades and pursuits, especially in cases where we're suspecting a paralytic strabismus, even checking the AC by A ratio by gradient method or haploscopic method, where the distance and near angle disparity is large. This is especially important for patients with accommodative esotropia. Also, looking for any kind of abnormal head posture, nystagmus, syndromic features, neurological signs, and abnormal behavior of the child is important. Coming to the classification framework, how do we document these? First, being the direction of the kind of squint. Second is the onset. If it is infantile, that is less than 6 months, or it is something which is acquired. If it is constant or intermittent, and what kind of committance is there? That means, is it equal in all gazes, or is there some kind of incompetency that is present in different gazes, which can be present in cranial nerve palsies or even myopathies like myasthenia gravis. So, further, the etiology, that is, if it is accommodative versus non accommodative, if it's post traumatic, post fractures, everything needs to be documented. But there are some red flag signs that we all should look for in every patient with strabismus. The first one being abnormal red reflex. So, if there is an abnormal red reflex, there is a possibility that it could be a retinoblastoma or an RD or any kind of a tumor that we might catch, and this might be the presenting symptom. So, always, any person who is not even in the ophthalmology branch should refer such patients to the ophthalmologist. Second is an limited abduction. That is, if there is a sixth nerve palsy, that is what is more common in children, that could be actually a sign of raised intracranial pressure or a sign of any intracranial tumors or any problem in the nerve pathway. Children with third nerve palsies, with sixth nerve palsies, or even congenital fourth nerve palsies have to be evaluated thoroughly. Diplopia, headache, or nystagmus, these may indicate intracranial or posterior fossa pathology and should be evaluated completely. Further, compensatory head posture. If a patient has a head tilt or a head posture that has suddenly developed, should be also catered for and should be looked for. Neurological features like cerebral palsy, developmental regression, or signs of ICP has to be looked for. Therefore, thorough examination of the optic disc is very much necessary in all these patients. Strabismus can actually be a presenting sign of retinoblastoma or intracranial tumors or raised ICPs, and therefore never dismiss without a red reflex assessment. Now, Coming to a broad classification of type of strabismus in children, which is more commonly seen, if there are committant, it could be an infantile esotropia, accommodative esotropias, AACE, that is acute acquired committant esotropias, sensory or intermittent exotropias, manifest exotropias, or even pattern or monofixation syndromes. Now, paralytic strabismus like congenital lesopalsies, third, fourth, fifth, as we discussed, other kind of squints like in CCDD, including Brown's, Duane's, congenital fibrosis, can be present but rare. Myopathies like myasthenia can also be present, and it should be looked for. Patient should be asked for any diurnal variation or any kind of ptosis that is present, that should also be catered to and looked for. CPU, of course, is very rare in children, but others like orbital fractures, craniostenostosis, patients with monoocular elevation deficit, everything needs to be looked for. This is the broad classification of ESO deviations, and now further, the acute acquired committant esotropias have been further classified from more than the type 1, 2, 3 to 7 total types of AACE. Intermittent exotropias, that is again a broad topic in itself, and there are various classifications to that, and various amount of things that have to be looked for in these patients that we have covered in motor and sensory examination. A little bit about infantile esotropias, how we should differentiate it from other kind of esotropias is that these are occurring before 9 months of age. They typically have a large, that is more than 30 prism diopters of esotropia, and they are stable. They can be associated with DVDs, inferior oblique overaction, latent nystagmus, and usually the refractive error is low and glasses are rarely correcting the deviation. Surgery before 2 years of age actually optimizes the binocular outcomes in these patients, and the earlier we intervene, the better it could be for the patient. It's also there's something called an OKN asymmetry, that is the optokinetic kinetic nystagmus asymmetry, that can be found in patients with infantile esotropia, even if they present later in age, that can help us in differentiating it from other kinds of esotropia. The next being the spectacle prescription. Now, this is something that is very, very important in every child with strabismus. We should prescribe a full cycloplegic correction. This is the single most important non surgical intervention, especially in patients in accommodative esotropias. A full hyperopic correction can directly reduce the accommodative drive, resulting in complete correction of the esotropia itself. Bifocals considered for near excess accommodative esotropias with high AC by A ratios are also considered, and a trial period of at least 6 to 8 weeks with full time wear of glasses should be given before reassessing the residual deviation. Some children achieve a full ocular alignment alone with glasses, and therefore, going ahead with a direct surgical option is not necessitated before we prescribe glasses at all. Now, this is the AAO criteria for glass prescription in children, and as we see that patients with esotropia, the hyperopia amount that is expected to be normal is much lesser as compared to that in others. Accommodative esotropias are usually seen where the hyperopia amount is more than +3, and a full cycloplegic correction gets rid of the esotropia completely in almost 30% of cases, which is a large amount. In patients where even after cycloplegic refraction, we feel that the squint is only partially corrected, atropine refraction is a must in that situation, so that we can unmask any kind of latent hypermetropia that we have missed, or unmask any kind of accommodation that we have missed. So, a non refractive or a high AC by A ratio component can be corrected by bifocals, where executive lenses play a great role. Further, surgical planning of the residual amount after full optical correction over a period of time should be done, and we should operate the residual amount and not the full angle. You can see this is a patient with esotropia, where an executive bifocal was given because the patient had an eye AC by A ratio. And as you can see, the distance esotropia has completely been corrected with this distance segment. Now, the very important fact for executive bifocals, even in this child, would be that the frame should have probably been a little more larger towards the up, so that the executive part or the executive portion of the glass bisects the pupil. That's the main thing in executive bifocals, and that should be taken care of. Further, coming to the amblyopia management. Now, treat amblyopia before any surgical correction is taken into account, so that we can give a better binocular outcome post-operatively. So, first optical treatment should be given at least for the first 6 to 12 weeks, as many children can improve even without any amblyopia intervention. Further, patching or occlusion, that is our traditional way of treatment of amblyopia, helps tremendously even in patients with intermittent exotropias or patients with intermittent esotropias. Just by patching an improvement in the vision quality, they might even overcome their squint or strabismus. Other options like atropine penalization or binocs have also come up and can be used in patients with amblyopia. And the goal is basically to reach equal or near equal visual acuity in both the eyes before any surgical intervention is thought of. A reassessment with glasses is a must. So, after we give glasses, within the next 8 to 12 weeks, we should reassess the patient for squint with these glasses. In case of a fully accommodative type, as we discussed, there's no surgery that is required. Where it is partial accommodative type, first get an atropine refraction and then further surgical planning can be done if there is no improvement or increase in the glass power that is required. Now, surgical versus non surgical correction is another step. So, non surgical options like ground prisms or Fresnel prisms or even botulinum toxin injection in some cases is there, like in cases of acute or committant esotropias or any post-operative overcorrection of a slight amount can also be corrected with Botox injections. Surgical correction like recession, resections, in some patients with different kind of squints, like paralytic squints. There are various options that are present for correction. And the goal of the surgery is basically to restore the ocular alignment, promote binocularity, and even improve cosmesis. But remember, if the patient has amblyopia, we should always continue the amblyopia therapy even post operative. Non surgical options like orthoptics or pharmacological options are also present, as we had already discussed. So, patients who have a convergence weakness can all definitely go ahead with pencil push up exercises, block string exercises, even fusion cards. Computerized convergence programs have been started nowadays, which help a lot in increasing the amount of convergence. But even the uh, with the presence of Botox or botulinum toxin, it is quite effective, but it is something that lasts for a few months, that is maybe 3 to 4 months, and can be used in patients with small angle esotropias or an acute sixth nerve palsy or a post surgical overcorrection, but obviously only after thorough evaluation of why this kind of an acute sixth nerve palsy is taking place. First and foremost, that is the most important point. So the question arises when to operate. So the first thing is when the squint is non-resolving with any spectacle correction or other non-surgical options as well. Second, being constant deviations or squinting more frequently in the recent past. Any intermittent esotropias or exotropias turning into constant or a reduced stereopsis, a negative effect on social interactions, abnormal head posture, lack of binocular single vision, lack of stereopsis, or to improve the effectiveness of amblyopia therapy itself. These are some of the happy patients post surgical intervention where they could get the alignment and further help their visual prognosis. So, the key takeaway is one, refraction is first, and always perform a full cycloplegic refraction before planning for any kind of surgical intervention. Second, being treat amblyopia first. So, post operative vision assessment is also required, and if there is amblyopia that remains, we should continue the treatment post-operatively as well. Third, being set realistic expectations. Motor alignment is achievable, but obviously there are chances of under and overcorrection. Plus, sensory fusion depends on the age of onset and the duration of the misalignment. Long-term follow-up is not negotiable, and squint and amblyopia can recur even later, and therefore sustained vigilance is important. I hope
Thank you.
I have finished well in time, and we can have a good amount of discussion.
Yes, thank you, Dr. Divya. The topic is a very vast one, and you have
Yes.
precisely concised it, crisp and to the point. Thank you very much for this brief summary of the topic. I request Dr. Manjula and Dr. Sreepathi to share in their inputs regarding the topic before going in for discussions. And I also request the members to post in their queries so that we can have a good discussion about the topic.
Thank you, Priya. Can I start first? Actually, when a small child walks into the OPD, and even before you see the child, you will be talking to the parent. And when you are talking, as you're talking to the parent and taking down the history, you have to observe the child. This is even before examining. There are so much of inputs you can get when you just observe the child in your OPD room. So you have to see whether the child is fixating, is the child having manifest strabismus, is the child having any anomalous head posture. So all these things you can quickly judge as you talk to the parent and take the history of the child. The first examination visit to the child should be as pleasurable as possible. So you do not want to irritate the child because the child is anxious, the parents are anxious. We want to keep them as comfortable as possible. So start with your sensory test. On the very first day, just do only the sensory test. Don't start with motor test. So sensory test would be vision assessment. As she rightly pointed out, you have to document your vision. So you have to use, according to the age and the ability of the child, some method of visual acuity documentation, because then only it will be a reliable method for follow-up of the patient. Once vision is assessed, then you have to look for fixation preference. Now, the fixation preference only, the CSM comes. Many people record CSM as vision. CSM is not vision. CSM is fixation preference. Is the fixation central? Is the fixation steady without nystagmus or oscillations? Is the fixation maintained? When you feel that the child is not maintaining fixation through blink or through smooth pursuit, or when you remove the cover from the preferred fixing eye, if the fixation alternates very quickly, that means it's an ill-sustained fixation. These are important points because we want to judge amblyopia in a pre-verbal child, in a child who's not even going to read your alphabets or do even picture matching or even do any other form of visual acuity measurement. So how do you get all this? Only by these sensitive small methodologies. Then the next aspect is give the Lang's card. Lang's card is such a beautiful card. Priya will be knowing it. We are having that in our OPD because it's a card where you don't put any spectacles. There's no depolarizing glasses. There's no red and green glasses. You don't put anything on the child. You just give that card and ask the child to point out the popping object. So if the child has stereo, that means this child has got reasonable visual acuity in both eyes. This child has a strabismus, which is well compensated, well controlled, and this child is really doing well. If the child has got stereopsis, you're going to stop with this. There is no other sensory test needed. But in case your child does not have stereo, you go to the next level of test. What is the next level of test? Is this child having fusion? That's when you will do the birth photo. You don't even have to have a Snellen chart to do the W4T3 test. If you just have a torch, you can move the torch from the end of the room closer to the child. So you will get the birth photo dot for distance as well as near. So the child will be able to, any verbal child will definitely be able to tell you the number of lights that is seen. Suppose a child has got strabismus and the child has got fusion and the child does not have suppression, what does it indicate? it indicates that the child has an ARC. You have a strabismus, but child is fusing. Where is it possible? Only if the child has ARC. So then the next level of test you will go. Stereo is present, you stop all the tests. Stereo is absent, you're going to fusion. Fusion is present, but there is a strabismus. Then you go to the next test. What is it? Test for ARC. For ARC, the simplest thing that you can use is Bageloni striated glasses, where you will see the striation cross, just like how a normal patient will see. So once an ARC is established, now you've gone to the stereo fusion, everything is, the rest of the sensory tests are, if you want, you can do it. If you don't want, you will not do it. They are the fusional amplitudes and the AC by A ratio. Once this is all done, these can be done only in older children. So when you check fusional amplitude, please do divergence before convergence. And AC by A ratio only when you see that there is a near distance disparity. These are all special tests. These are tests that are not warranted in every child. Only then you will go ahead and do this test. Then you come to the motor test. The motor test can also be done on the same day, which is basically evaluating the amount of deviation which your child is presenting by using prism bar cover test. The prisms that you will use in a small child is not a prism bar, though it's called PBCT. What you will use is loose prisms. These loose prisms give very good visualization of the child's eye. The child will also be able to see the fixation target very well. So it's very easy to do it with loose prisms. And you can also measure both horizontal and vertical deviations by stacking these loose prisms one on the other. And always use your Spielman occluder, because you can see the eye under the cover and your judgmental value becomes so much higher when you use these loose prisms with your Spielman occluder. So when you do the motor test, measure for distance, measure for near. When I say distance, the target, it could be even a play toy or it could be a cartoon playing on your TV screen. We all have these Apasami's ice screen, which has cartoon and films playing at the distance of the rear end of the room. So these are accommodative targets. You need to suspend accommodation for distance. That is why you give an accommodative target at 6 meters. An accommodative target at 6 meters will exert a 1/8 of a diopter of accommodation. What is that? That is a very negligible amount of accommodation. You don't want accommodation acting on your distance deviation. You want to measure the deviation without accommodation. So give a distance target which is accommodative and measure your distance measurement. The same thing, you give an accommodative target at near to get a measurement. Now here you want accommodation to come into play. Your near deviation has to be with accommodation. Your distance deviation should be bereft of accommodation. So this is the reason why you give accommodative targets for both distance and near and measure your deviation. This is more than enough. If at all you suspect a pattern, do it in up gaze and down gaze. And if you suspect a lateral incompetence in a small child, these things really don't matter. You can do the side gazes also. So this is the motor evaluation. Once you've done this, now you want to know what is the refractive status of the child. Yes, you want to dispense glasses. So call the child for dilatation, if possible, on the next day. Don't do it on the same day. And allow your PCA or the child to be dilated in some other room, because the child is going to come back into your room. You don't want the child to resist you. So once that cycloplegic dilatation is over, that time you will assess the child for glasses, and you will also see the fundus, because all these children, they can have IRDs, they can have coexistent optic nerve abnormalities. There could be so many other issues in the retina of this child, and a good anterior segment evaluation. So you'll go all together on the second day. Once you have the glasses, given the glasses, again you call the child for another evaluation of your strabismus and see whether there is any changes in this strabismus. So apart from sensory, motor, cyclo, anterior segment, fundus, dispense glasses, and again measuring the deviation, you have certain special tests in strabismus. And what are these special tests? One is if the child has got any kind of head tilt and you suspect an SO palsy, you would do a torsion assessment. Superior oblique, the greatest torter on our eye. So you will have to assess the torsion not only in primary gaze but also down gaze, which you will be doing by lifting the chin. So you will use the Bagaloni striated glasses and look for the torsion. So this is one way. If there is a head tilt or a head turn, you can also assess this head turn and head tilt with a goniometer, which is nothing but just two scales fitted with a protractor. You can assess that quantity. This is also a special test. Suppose it's a paralytic strabismus or a restrictive strabismus, you do two more special tests. What are those tests? The force reduction test and the force generation test. They are so much of added value. Please do these tests before you decide on your next step. Once you get all these things, and if there is amblyopia, you've treated amblyopia, then you embark on your management of this patient. So I just hope you get this flow. I want the beginners to get this flow. We don't do all tests in all patients. You do a titrated test depending on the need, depending on the sensory status of the child. Of course, cycloplegic, fundus, anterior segment, this is there for all children, irrespective whether there is strabismus or not. But when it comes to strabismus, you will decide at the level of sensory test what will be the next step in progress. And then you will do the motor test. I hope you all got it, what I'm trying to share with you today. Priya, any other questions?
Yes, ma'am. Thank you, ma'am. That was very clear. Dr. Sreepathi, sir, your inputs?
See, it's always pleasure to hear to Manjula madam. Like it's whatever you are, how old you are, whatever, it doesn't matter. The way she puts the things is amazing. And exactly same thing. Each and every mature pediatric ophthalmologist would want to do the exact things what madam told. I don't think she has excluded anything. And Divya, very beautiful presentation, precise and neat. Yes, of course, we cannot cover so many topics in one go. It needs lot of so many tests and this thing in one shot. But you have done it very beautifully. So
Definitely.
I would like to congratulate you. And madam, really hats off to you. Thanks a lot for making my job less.
Thanks, Sreepathi. Thank you so much.
Yeah.
So I have a few questions lined up. So the first one would be, how is pediatric squint different from an adult squint?
Pediatric squint is different from adult squint because you have to very quickly assess the patient. You have a very short time period. The child doesn't have too much of attention. So you have to do all these things. That is why I enumerated the order in which you will see this child. So within that short period of time, you need to extract as much information as possible from the child to make your diagnosis. And there are certain kind of strabismus which will be present in the pediatric age group. For example, an infantile esotropia. That is mainly you will see only in a pediatric age. An intermittent divergent squint, which is controllable, where fusion is there. Only when you disrupt the fusion, when you dissociate the eye, the squint will be manifest. So that is present in childhood. All your CCDs, they all present in childhood. They're all present from birth. For example, your Duane's retraction, your Brown syndrome, all these those with your head tilts, your congenital SO palsy. So these are squints that are very much, pediatric presentation skills. Now, in case of adult squints, what kind of squints? It could be a decompensated heterophoria if it's an adult squint. It could be neurological squints because of a third nerve, sixth nerve, or even an acquired fourth nerve palsy. These kind of squints will present in the adult age group. And then when you have orbital fractures, restrictive strabismus is in the adult age group. So the kind of strabismus you will see in the pediatric age group will be far different. The evaluation is also the way you will see the child, how fast. Adult, you can take all your time. You can do in any order. You can do motor, then you can do sensory. You can dilate on the same day, do FDT, FGT, in the OPD, everything. You have the liberty to do as many tests, as much time. He's going to cooperate with you. Pediatric is a different ball game. The child will not show their eyes to you for more than 10 minutes. In that, you're going to make an objective measurement of the vision, the fixation preference, the presence of amblyopia, the sensory status of the child, and the motor evaluation. And also look at the anterior segment and the fundus and come to an inference. What is the diagnosis? And am I going to interfere with the child right now or not? So this needs far more competency and far more ability than when assessing an adult strabismus.
Divya, any inputs from your end?
Yeah, one more thing I would like to add up is
Yes,
Madam told everything. Basically, the size of the eyeball, it really is very small. In a pediatric, the size of the eyeball is lesser. Up till age of 8 years, it keeps increasing in size. So the arc of contact of the muscles compared to adult, there will be some certain amount of variation. Hence, the results of pediatric surgery, pediatric squint strabismic surgeries, vary with that of the adult strabismic surgeries. The results the
Outcomes.
results what we get with 1 millimeter to 2 millimeter, that chart doesn't hold good for pediatric age group. There are two reasons again that development of the muscle pulleys is again different, and the actual insertion, the strength of the insertion, so many variations are there with that of the pediatric compared to adult.
Definitely. As said, I think everything is covered. So, apart from that, even the presence of amblyopia, binocular vision, we can develop it maximum in the pediatric age group. So, dealing with these children in a proper, appropriate way is very, very important because you can actually make their binocular vision much better.
sure. Thank you. And from your slide, you have mentioned that suppression and amblyopia can coexist. So if so, then how do we delineate it from a clinical test?
So, suppression is something that is present only binocularly. Amblyopia is not that. So, amblyopia can be present monocularly also. So, if a patient is having suppression, when the patient is seeing with both the eyes, and as we were showing the different kind of tests that can be done, even if you're doing Bagolini, suppose, and the patient is not able to see the central part of one of the line because of suppression, but as soon as you occlude one eye, the central line will be visible. That means it's just a suppression and not an amblyopia. So amblyopia means that the visual capacity of the patient is less. In suppression, the patient can have a 6/6 vision also and have a suppression still. But in amblyopia, the vision is going to be less. So that's how we can differentiate both of them.
So, and this also emphasizes that amblyopia therapy needs to be continued even after doing any kind of
Yes.
strabismus surgery.
Definitely.
Thank you. Okay.
Priya, one point, Divya rightly pointed out those things. An amblyopic patient will suppress actually, but a patient who's suppressing because of strabismus may not have amblyopia. The converse may not be true. This may happen, but that need not be. So amblyopia is by vision testing and fixation preference. Suppression is by your birth for dot or your Bagolini's triangle classes. So you'll use different kind of tests also, clinical tests also to delineate.
What is the role of NRC and ARC in view of evaluation for squint surgery? How does it changes or manipulates our dosage or our planning of squint surgery?
Priya, actually ARC is where the patient is not suppressing but is showing fusion. That is the normal foveal point and that abnormal point in the retina have developed correspondence, which should not happen. So what happens after strabismus surgery is you will get a paradoxical diplopia. Now the whole equation changes. You don't have diplopia before surgery. You have fusion. Before surgery, what you see is fusion. A strabismic patient is fusing. On the birth for dot, there is fusion. On the Maganoni striated glasses, there is fusion or a normal X cross, which you will see in a normal patients without heterotropia. But after you operate, the patient is going to really be on your neck. There is going to be diplopia. But this is the bad part of the story. The good part of the story is this diplopia is only short-lived. It's not a very strong correspondence that they develop. The paradoxical diplopia goes away with that. Suppose we are not testing ARC, we are seeing patients with fusion and strabismus, but the number of cases we see is very less actually, Padma, because we have been practicing for so long. We clearly don't see so many cases of ARC.
Yes, agree.
But you
Agree,
can
madam.
have a word of caution to patients and say them after the surgical alignment, there is a possibility of paradoxical diplopia. Sreepathi wants to add anything? Sri?
No, madam, I agree with you. Very rarely we come across, maybe in my 20 years of experience, hardly I've got 3 to 4 patients of ERC.
Correctly said.
Yeah.
I have seen only one. And you have to counsel them pre-operatively and post-operatively, saying that pre-operatively, the likelihood of diplopia, post-operatively, you have to tell them it will disappear. You align now, there is no misalignment now, but you are having some kind of sensory issues, which is going to dissipate with time. So with time, they are going to do better.
So, your experience of Botox and Squint management, both Dr. Manjula ma'am, Dr. Sreepathi, and Dr. Divya.
Botox, Priya, I give it in a very reserved, small segment. Nowadays, in the UK, whether it's Moorfields or anywhere else also, a lot of people say that they give Botox even for comitant squints like infantile esotropia. But I actually give it only in 2 settings. One is when you have a paralysis and you're waiting. You wait, there is a window period of 6 months you wait. So meanwhile, your antagonist will undergo a contraction. I'm giving time for spontaneous improvement or spontaneous resolution to happen. At the same time, I don't want that muscle to have a contracture, the antagonist to have a contracture. Then during the early stages of the palsy itself, not after 6 months. I don't prefer giving Botox after 6 months, but before 6 months, initially, I would give Botox into the antagonist muscle. That is one thing. The other thing is I do it in thyroid ophthalmopathy a lot of times because again, there your muscle texture changes. It's a restrictive strabismus where you have your glycosaminoglycans and things like that getting deposited. The muscle volume and the texture changes. So your restrictive strabismus, even if you're going to do your surgery, let's modulate the muscle. I would give on the table my Botox injection. But the only thing is, the Botox which I give in restrictive strabismus would be slightly more in units as opposed to the Botox which I would give when I give into the antagonistic muscle in the paralytic strabismus. There would be a slight difference in the units I would render into the muscle. So these are the only 2 situations. In India, we have still the liberty of operating on patients. Patients want surgery and we do surgery in most of our patients. So comitant strabismus, I am not of the preference to give botulinum toxin. That is my personal view. Sreepathi and Divya can add their...
No, madam, I don't have personal experience about with Botox.
Yes.
I don't give this thing. That's what normal school of teaching, whatever we were taught, like try to be away with it. That's what we were taught from beginning. Because of the post-Botox complications or post-Botox
Yes.
manifestations are a bit weird. So I don't have personal experience.
Just one point I want to add for beginners. I find beginners giving Botox in a nerve palsy like a 3rd cranial nerve palsy. Please refrain from doing that. Botox is reserved for single muscle palsy. For example, 3rd cranial nerve also is a single cranial nerve, but it supplies multiple muscles. You cannot give it in 3rd cranial nerve palsy. Please don't do that. Please reserve it only for 6th nerve palsy, where you'll be injecting the Botox into the medial rectus. You cannot do it even in SO palsy. You cannot inject Botox into the inferior oblique. So these are the things, we can follow things, but follow things as per guidelines. Don't do as per your wishes or fancies, because there are protocols in uh, every part of ophthalmology, more so in strabismus, where it has to be strictly followed, because results can go haywire, patients can have haywire problems, and you do not know now what to do next, the next step of dealing with these patients. That's when complications arise.
Dr. Divya, any inputs from your end?
I think same as ma'am said, even I go ahead with Botox mainly in patients with sixth nerve palsy in the acute state, just to wait for those first 6 months and to relieve them from how much ever diplopia if possible. So those are the cases that I have experience in.
Okay. And a few questions from viewers. And what is the most common squint in newborn?
We would put it as infantile esotropia, most likely to see infantile ETs, because that is usually within the first 6 months of life. And apart from that, every newborn can have some amount of small misalignments. So the first 3 months, it's common to see XTs more than ETs, actually in the first 3 months of life. You wait. So don't make a diagnosis of any strabismus in the first 3 months, even if it is manifest. You wait for spontaneous resolutions, ocular fixation to develop, and things like that, and look at the alignment after 3 months. So after 3 months, we would say that infantile ET is the common kind of strabismus encountered in our practice.
Thank you, ma'am. And one more question is, what is the optimum age of surgery to recover binocular vision? And one more that he's asked is, what is the duration of use of bifocal glasses? Maybe that he has mentioned it for usage in high AC by A ratio.
Now, in case of infantile esotropia, the school of thought is do it as early as possible. So when can you assess this child? Minimum will be 1 year or 1.5 years. At least you should get an approximate measure of your angle of deviation. So 1.5 to 2 years, then don't embark on surgeries without a measure on your paper. Don't do that. That is a very bizarre way of going. So at least an approximate measure, near approximate measure you need. If not exactly a good PBCT, at least an approximate PBCT. So once you can do that, that depends on the cooperative ability of the child. It could be 1.5, 2. So infantile ET, though they say 9 months, 6 months, 1 year, you may not be able to measure the squint. So you have to do it when you can measure, that would be 2 years. And since there is absence of central fusion, this squint itself is associated with absence of fusion. So even if you operate it early, your binocularity is not going to be restored. The best thing that you can get is a monofixation syndrome in case of infantile esotropy. IDS, when do you see the squint itself starts manifesting 2.5 to 3 years. So 3.5, you'll be able to measure the strabismus. So 3.5 years, if you have got a good PBCT and you've assessed the squint fairly well, and if you as a surgeon, you're confident of the surgery, you can go ahead and operate the child as early as 3.5. If you as a surgeon, you're not confident or you're not able to, it's a very attention deficit child, a child who is not cooperative at all, then you'll have to wait. Either one of these conditions, you'll have to wait long. And what is the other question? Bifocals. The bifocals, you will be giving it during the entire child. Suppose you start at 4 years or 5 years, until the AC by A ratio, the AC by A ratio will tend to normalize as the child grows. It's not going to be high. That's again a dynamic value. At 4 years, when you get a high AC by A ratio, it's not going to be the same at 12 or 13 or 14. That time it will be much lower. So you wean off the bifocals when the child grows into adolescence. So the period of childhood will definitely have, because you do not want the near ESO also. The near ESO will again affect your binocular function. So during the development, if you want fusion for both distance and near, then you need to keep the child on your bifocal glasses.
Got it, ma'am. Thank you. And do we have any management for microtropia, central suppression scotoma, ma'am? Does the anti-suppression...
Microtropia, you don't have to. See, suppose the child has got a little bit of hypermetropia, you can give glasses. Most of these patients with microtropia will improve to 6/18. They'll have gross stereopsis and there is peripheral fusion. There is foveal fixation this side. There is a small suppression scotoma close to the fovea and the other eye. But what happens to the rest of the periphery? So beautiful in strabismus, it's fusing. The angle is so small, peripheral fusion is existing. So these patients will have peripheral fusion, fair amount of vision. The amblyopia is not bad. It's going to be 6/18. Your BCVE will be 6/18 or slightly lesser than that. And you're going to have peripheral fusion. It's a very stable condition. So what do you want to treat? I would not even embark on any amblyopia treatment in these kids. They're doing well on their own. Leave them alone. Both motor as well as sensory. Let's put it like that. And that amblyopia is not going to change.
And one maybe final last question from my end. It is like now we have more of myopia progression control management. So what are the factors that we need to look into when we give these kind of modalities for children with squint? Myopia
If you're
progression
giving,
control
if
glasses.
it's an IDS, good control, anything can be given. Low dose atropine is not going to affect your accommodation much. Your glasses also, you're worried whether your glasses are going to be effective. Your glasses also. These are the common things, isn't it? If it's a poorly controlled IDS, then of course your glasses are not going to work. But if you have still your myopia progressing, LDA may be a better option.
Okay, but we should look into that squint aspect before
The
giving
squint aspect is better. The squint aspect is better. And do not overcorrect these myopes. Let me tell you. Because overcorrection of myopia in IDS is also a specific entity. People keep doing random things. It actually ends up only in asthenopia, nothing else. Overcorrection is not going to, for heaven's sake, control your squint in any way. So don't overcorrect your myope when you're going to give a myopia control therapy also. Don't do any of those things. Myopia as per the norms of myopia treatment and myopia progression, maybe the most suitable option would be your LD.
And one more question from the viewers end. What is the best method to assess the presence of ARC? Is it Bagolini glasses?
Yes, of course, yes. Bagolini glasses is your best method of assessing. That's the simplest and the best method. Please buy a pair of Bagolini glasses and keep it in your OPD clinic. Okay, it's part of your tools of trade. We have very little tools of trade, but one of it is Bagolini glasses.
Yeah. Thank you, Dr. Divya, for that wonderful presentation. And I thank Dr. Manjula and Dr. Sreepathi for their valid and very useful inputs for us beginners. Thank you so much. And I thank the clinical board for this beautiful meeting. Thank you.
Thank you all.
We
Thank
wind
you
up
all.
this
It was a
session.
You all.
delightful
Thank
session.
you.
Thank you.